I'm here with Manjool Shah, a member of the ASCRS Yes Committee. Manjool, when the whole sort of glued haptic IOL thing came out, I thought that it was just like as slick as sliced bread.
Yeah.
And, I was not, I don't look for cases for it. And one hasn't shown up, so I haven't had to think of sort of the other side of that coin. Of course, the technique has been further refined by Dr. Yamane, and we're talking now the sort of the two needle technique, in which the needle is also used to make almost a little tunnel to sort of tuck the haptic in, and the haptic is widened as a little ball. Anyway, you know this stuff better than I do. You see this brilliant stuff, at least I do, and the first thing that comes to mind is not what the complications are that can arise from it, but that is something to consider, and you have considered it, and let me have you sort of spell out the topic of your lovely talk.
Sure. So, with any IOL fixation technique, we have to worry about contact between the IOL or the implant and uveal intraocular tissue. And there is a real risk of developing UGG syndrome type pathology. So there's a couple ways that it's really easy to get UGG after any of these scleral fixation techniques.
UGG, I mean, obviously being uveitis, glaucoma, hyphema. Yeah.
You got it. Or quite frankly, any irritation of the uveal tissue may not actually manifest as uveitis, glaucoma, and hyphema. So it's important to recognize that. But by placing an IOL appropriately posterior from the iris surface, or the posterior iris rather, we're able to prevent inadvertent IOL contact. So one real easy pearl to make sure we're well enough posterior is to measure back not just from the limbus but from the scleral spur, so that blue-white transition. And I typically measure about 2 millimeters posterior to that for any of these double needle fixation techniques. The other way to really ensure that we're nice and posterior is make sure that our needle track is perpendicular to sclera, so we don't actually emerge more anterior on the inside of the eye than we think we are.
So is the mechanism of irritation the IOL to the iris surface, or is it the haptic to the ciliary body? I mean, what's rubbing on what?
And we've actually seen both, actually. So we've seen situations where the posterior iris is being irritated. We've also seen issues where the haptic actually goes right through the ciliary body. So keeping things posterior and angulated away from it is a really good way to avoid that. The other way to avoid that is to place a peripheral iridotomy at the time of lens implantation. We do see a small rate of reverse pupillary block in these eyes, especially ones with no vitreous and a really prominent iridodenesis. So placing an iridotomy really keeps the iris away from the IOL. Okay,
so I understand your pearls, and of course they all make sense. But let's say that, I mean, what do you do once it's happened? Once you have a patient with a glued-in lens and uveitis, these I imagine these are not the easiest cases to explant the lens.
Yeah, you make a really good point. It's amazing. In the few that I've had to reposition or explant this Yamane double needle technique, it's really embedded in sclera. So I've had a few patients where I've actually trimmed off the bulb of that terminal haptic and then re-docked the whole haptic more posteriorly, again, more away from the ciliary body and iris.
Oh, interesting.
Yeah. So you can get away with a reposition sometimes, which is really elegant because you're only working with really small 1 millimeter paracentesis incisions. Again, sometimes it's as simple as placing an iridotomy, and occasionally eyes just don't handle structures going through the eye wall, and you may have to consider alternative IOL strategies.
Yeah, really, really interesting. I mean, the technique is so new, but it's really cool. I mean, it's really, really neat stuff. Yeah. Manjool, I want to thank you for bringing this neat topic to us, making it all sound, I've no doubt, far simpler than it actually is. And as always, for being so very generous with your time with us today.
Thank you very much.